Welcome to this lecture on the RTT profession. This is very much my personal held opinion on where we are as a profession and where we're going in the future. But I really do hope that you will share some of the concepts and ideas and make our profession strong going forward. Thank you. I think it's important to start with what we consider to be the definition of a profession and to see how the RTT profession fits within that definition. And it relates to any type of work that needs special training or particular skills. And generally, it involves higher level education. And you'll see in the second definition from Wikipedia that it's a profession which is an occupation founded upon specialized education and training. It's also with the purpose of service to others rather than for individual gain. And I think that very much encompasses what RTTs do. And then I think we have to look quite honestly and see, well, do RTTs currently meet this criteria? I chose this quote from the EORTC because I thought it encompassed very nicely what is the reality in our profession. And there really is a very large variety in the definition of tasks or roles and responsibilities carried out by RTTs globally. In some countries, they're highly specialized with a recognized diploma or degree, and in other countries, they may simply be people who receive in-service training without having the recognition that goes with it. And I think this is really very important because it will determine how we as RTT professionals define ourselves in the future. And then, even more importantly, what will the education institutes do to provide an education that supports RTTs to meet this definition of a professional? And I think it's important when we look at the RTT professional to actually put it in the context of where radiotherapy is, both now and where do we expect it to be in the future. And I think we can very easily say that all aspects of radiation oncology are dynamic and they're rapidly evolving. This is in the technology field where we have major developments ongoing all the time, but also in technique. And the changes in technique are very much guided by evidence and built on research. And I think we've seen some very interesting studies in fractionation, for instance, as a result of COVID. And these now will become routine practice in the future. And the RTT profession must keep a close eye on these developments, and it's really important that we evolve as radiotherapy evolves. And that involves reviewing and rethinking our current practice so that we can keep pace with developments in technology and practice. And there are several areas that we need to consider when we look at how rapidly radiation oncology is evolving. One thing is the increased demand for services and also the greater number of patients who are now being referred or for whom radiotherapy is appropriate. And that coupled too with a rapid expansion of radiotherapy globally, where radiotherapy centres are being set up or expanded where there is no real existing experience. And these create a great deal of problems for RTTs on the ground that can only be resolved when we define clearly what our professional role is and when we can match that appropriately with an education programme that supports it. We also have to look at the constantly emerging technology and the complexity that it brings with it. The many new techniques and fractionation schedules that move us away from routine practice where each patient is more or less given the same dose at the same time. Adaptive radiotherapy is on our doorsteps and is already existing in many centres. And then the big one is the increasing use of artificial intelligence and how we can use that to our benefit rather to our detriment. And the RTT as a professional must be prepared to meet the challenges of these developments and to work with them and make the most efficient and the best use of them. And we also have to consider that the future is already here as current practice in many centres. There are already varied and novel fractionation regimes in place for different sites. IMRT, SRT, SBRT, IGRT are routine practice in many departments for many RTTs. Where we have to look at when we consider that we are a holistic profession as opposed to a technical discipline, then the whole role of patient information, care, support and assessment becomes critical. And again, in many centres, this is the role of the RTT, but it isn't universal. And we will move towards individual treatment for patients. It's very much the aim ultimately of radiotherapy. And from the RTT's perspective then, we need to provide a clear and accurate description of the treatment preparation, treatment delivery, any potential side effects based on their specific situation. And we need to be able to support and assess the patient on their radiotherapy journey. And we have to bear in mind that in a radiotherapy department, the RTT is ultimately responsible for safe and accurate treatment delivery, as they are the people at the front line on the linear accelerator actually delivering the prescribed dose. So then when we start to look at the future and what it will look like and how the RTT professional will fit into that future, then adaptive radiotherapy will be a reality as routine practice in the future. And we must be able to take an active part in that process and be an equal member of the radiotherapy team in delivering adaptive radiotherapy. So if we consider adaptive radiotherapy and we look at the key factors that are necessary for effective adaptive radiotherapy, we know that as routine practice, RTTs are already involved in troubleshooting and problem solving as part of their routine daily work. They're involved in image review and clinical decision making in terms of is the patient fit for treatment on that specific day. But for adaptive radiotherapy, we also need to be able to look at landmark identification and make sure that it's correct. If we're using fiducial markers, have there been any shifts? We need to be able to evaluate changes in patient anatomy for whatever reason and any tumour shift that may occur. We need to monitor the patient's external contours in terms of weight loss or weight gain and how this might impact on the accuracy of the dose that we want to deliver. We need to monitor the patient's physical and psychosocial status, and merging all of those factors together, we then make a decision on what plan of the day will be implemented. And the technology to enable adaptive radiotherapy is already here, and it enables us to monitor the patient's anatomy and also to be able to monitor any changes that occur during treatment. And where the RTT as a professional has a role to play, they must be able to detect these changes, and then they have to take responsibility to respond to and manage the changes, because they are the first point of call within the department and obviously working within departmental protocols. It's also very important that any changes that they subsequently make must be documented, and then the appropriate personnel, such as the radiation oncologist, informed of the changes that were made. So as a professional then, the RTT has a role in implementing art in the clinical setting if it isn't already routine practice, in pre-treatment review of the patient prior to plan of the day selection, to decide on the appropriate plan for each daily treatment, to identify clearly when replanning is required, when the parameters are outside what is accepted within departmental protocols, and to work within the multidisciplinary team to deliver the departmental art framework and to apply research findings as appropriate. And this is very important for the professional RTT that they're active in that research process, that they're involved in regular service review and the implementation of evidence-based research in the area. And I think in summary, RTT-led adaptive radiotherapy will become routine practice. It's the most efficient and effective way of implementing this into routine practice. And it means that the professional RTT must check the treatment prescription and critically evaluate the treatment plan to make sure that they are correct in terms of the interpretation of the prescription in the plan. They need then to review the daily patient images and to check that again against the treatment plan. They need to check the patient's physical status and see if there are any changes that will impact on accurate plan delivery. And having analysed all of those factors, then they will select the plan of the day and go ahead and treat once the parameters are within accepted departmental protocols. Where necessary, they'll refer to the radiation oncologist, and it's really important that they participate in research and also regular audit of the practice within the department. And when we look more generally at some of the changes and the developments that are coming in the future, with this evolving and changing practice, it's very important that the RTT is recognised as an equal member of the radiation oncology team and also as someone who can make and enact decisions. As we know, radiotherapy is very much embedded in good team practice, and the professional RTT has a moral and ethical responsibility to distinguish between good and bad practice and to always only accept best practice. In this context, they cannot just carry out tasks as requested. They mustn't be afraid to intervene or lack the confidence to query a decision. They should have the freedom to question, comment, or suggest on any aspect of the patient and their treatment. And of course, it's really important that they apply safety concepts at all times. And the RTT can contribute significantly to the treatment and care of patients, and also to all other activities such as protocol development within the department. They should be able to meet new challenges and adapt to changes in the environment, and they should be able to apply their knowledge in the clinical setting and thereby implement or suggest changes where appropriate. And RTTs will need to be able to make decisions based on their knowledge and understanding and to become reflective practitioners. And that involves integrating technical knowledge and a patient-centred approach. And looking to the future, we have to consider carefully artificial intelligence and its increasing use and how it will impact on all our roles and responsibilities and working practices in the future. Artificial intelligence and its increasing application in radiotherapy is very exciting. Potentially, it will improve technical capabilities and the overall quality and safety of cancer care delivery. When we look at artificial intelligence, however, we have to look at the fact that there will be some loss of clinical and technical skills, or maybe not loss, maybe change, and there may be gains of others. What's important is that we understand the applications and limitations of the multiple AI tools of the future, and we also need to consider very carefully and very importantly for the RTT, the novel human-machine interfaces that come with the increasing use of artificial interfaces and intelligence in our departments. And the future potential with artificial intelligence, I think, is quite endless. We should have increased efficiency in treatment planning, and that's already occurring. And it is shown that there can be greater accuracy with the use of artificial intelligence. It will make it a faster process, so that will result in shorter intervals from simulation to treatment. It will also facilitate online adaptive planning, allowing you for much more individualized treatment for patients. It will allow us to accurately define tumour and normal tissue volumes. And we can, through artificial intelligence, integrate clinically relevant data from a range of sources, and that will allow further tailoring of treatment approaches and greater individual treatment of patients. And it will also enable faster and better clinical trial accrual, which can be very positive in terms of providing evidence base for future treatment approaches. So then we need to look at the interface between the RTT and artificial intelligence, because it will not replace what we can do as human beings. And there is no doubt that artificial intelligence brings greater understanding. It can reason, it can learn, it can interact in a very different way. But as humans, and as RTTs in particular, we bring other attributes that are key to managing and treating our patients well. And they include common sense, imagination, morale, abstraction, compassion for our patients, which is really important in the context of where they are in their cancer journey, and generalization. And what is important for us as RTTs is to maximize our interaction with AI, and that's for the benefit of the patient and for improved practice. So let's have a little blue skies look at the department of the future. And we are moving as a discipline towards individualized, optimized treatment approaches. And I think that's very beneficial for the department, but it brings with it new challenges. And if we look at the range of technology and techniques that are under development, that we will be using maybe routinely in the coming decades, we can look at the MR-Linac, protons or other particle beams, techniques such as flash radiotherapy or PART, the increasing use of immunotherapy rather than chemotherapy and its interaction with radiotherapy. That's only to mention a few. There are many others that we can consider at a later stage, but these are techniques and technologies that will need to be integrated into our routine practice, and the RTT has a major role to play in leading that integration effectively. And if we look at one piece of technology that will be commonplace in our departments in the coming decades, and that's the MR-Linac. And from the RTT perspective of the deliverer of the treatment, then that allows us to visualize soft tissue much more accurately. So we can focus on the tumor and we can ensure that we minimize the normal tissue in the treatment volume. We can image anatomic and functional activity within the tumor. We can focus on critical organs, ensuring that the minimum dose levels are adhered to. It's even possible to vary the fraction dose during the treatment course, depending on tumour response. So very much individualising the approach to treatment for each patient. We can monitor patient weight loss or weight gain, and we can set up the variability based on this. And it's ideal for patients where tumour shrinkage may occur and where this becomes more critical. But there are other issues related to the MR-Linac that are different to routine practice on a linear accelerator, for instance. And that's, how do we manage the claustrophobic or the very nervous patients? We also have to think about the MR safety issues. We're dealing with a large, powerful magnet. And one might very well think about things like pacemakers or implants and how we check those prior to treatment. But you may also want to consider smaller things like jewellery or watches, for instance, and how they might impact. And then there are the issues of fire extinguisher location, oxygen cylinders if they're required. So these add a complexity to the daily practice of the RTT that has to be considered and taken into account. And then when we consider something like proton radiotherapy, which is becoming very much a part of the options that can be offered in radiotherapy, and it has many benefits, fewer beam angles compared to photon beams, very defined dose delivery. So for certain sites, this is an amazing benefit. But from the RTT perspective, there are issues that need to be considered in terms of how we practice on a proton unit. And changes to the distance the beam has to travel has an impact on the dose delivered. And that means that patient motion can be a significant problem when you're treating with protons. And the selection of sites is also therefore very important. Fitting of immobilization masks accurately and carefully, for instance, is critical in the proton setting, as is monitoring weight loss or even weight gain between fractions. You also have to consider organ or cavity filling, which is, as we know, a major issue in many aspects of radiotherapy. And the RTT has a major role here to play because accuracy is essential, as the potential for geographic miss is really quite enormous and has to be eliminated and managed carefully, which again is the responsibility of the RTT actually delivering the proton treatment. And then if we consider some of the new techniques that are under trial at the moment, and one of these is flash radiotherapy, and that's the delivery of ultra-high radiation doses in fractions of a second, maybe a few hundred times higher than the conventional dose rates we're used to working with. And flash exploits the radiobiological response, giving you more effective tumor management, allowing you to reduce target volumes, minimizing the volume of normal tissue irradiated. It means that patient motion is significantly reduced, as is interfraction motion, which can be minimized or eliminated. It allows for fewer and faster treatment, so you have more efficient use of resources, and it spares skin toxicity. But there are very critical safety issues that need to be considered. And the RTT, the professional RTT, really has a key role in ensuring that flash radiotherapy, when it is introduced into departments, is delivered safely and accurately. And another novel technique that's being trialled, at least in one centre in Switzerland at the moment, is percussion-assisted radiation therapy, or PART. And this is a very novel method to manage respiratory motion, where the breath is held for long enough to be able to carry out complex radiotherapy treatments. It brings about a prolonged apnea-like suppression of respiratory motion and the administration of small volumes of air which superimpose or replace spontaneous breathing. The additional benefit that was found from this technique was the expansion of lung tissue. But it again brings new roles and responsibilities to the RTT, who will have to manage the patient undergoing this procedure in terms of training them, of explaining exactly what's expected of them, and in actually managing and delivering the treatment under these conditions. And looking also at combined treatment, we're very used to treating patients who are also having chemotherapy, but more and more patients are now having immunotherapy coupled with radiotherapy. And of itself, radiotherapy has been shown to cause immunogenic tumor cell death by generating an immune response within the treated or the irradiated area. But when you combine radiotherapy and immunotherapy, this results in an even increased response in the treatment area, but also has an impact in metastatic sites, the so-called abscopal effect. And in this instance, when we look at how this impacts on our daily management in a department, then scheduling is really important, because this must be managed so that the timing of the radiotherapy and the immunotherapy are correct. We also have to consider that acute side effects can be greatly enhanced by immunotherapy. And therefore, we must understand this and know how we can carefully monitor and manage the patient who might be having immunotherapy as well as radiotherapy. So we conclude with the RTT professional who can function effectively in any department of the future. They can lead the introduction and management of technology. They're actively involved in the delivery of new techniques, including the evaluation of their application and effectiveness. The RTT can contribute to the professional profile of RTTs generally, And they can do this partly by actively participating in research. That can be in terms of clinical trial management, where they can prepare and participate in the initial evaluation of the suitability of the department to participate in a clinical trial based on their knowledge and understanding of the running of the department and the capabilities of the equipment therein. They can be involved in the discussions and certainly in publications and presentations based on clinical trials that are running in their departments. The RTT is also in a position to scope potential trials, to look at developing grants or working with groups to develop grants, to look at protocols, to implement and oversee trials within the department, and to publish and present their findings. It's also important that RTTs initiate research into their own practice and how it's implemented in the department and its effectiveness. And they should publish and present the findings of their work regularly at national and international conferences. And I think the RTT professional is at a crossroads currently. We're influenced by many external factors, most of which are outside our control. But we must remember that we are key members of the radiotherapy team, and radiotherapy is a team discipline. And we have expertise that is unique to us. And we can lead technological and technique developments within our departments to the benefit of the service and most importantly to the benefit of the patient. And I think we need to clearly define what our future is in that team. And we need to go forward, and it's a bright and exciting future for all of us.